It gives me immense pleasure in inviting Dr. Nalaji Palaniswamy, who's the Chairman and Managing Director of KMCH. Sir, if you could just address the gathering, please.
Good morning to you all. I was not able to come to this grand meeting of cardiac imaging yesterday. I am here today. We have this important imaging technique. We started in 1990s and now improved upon us from 2016. Now we have good technology to work with. And I am very proud that we have so many eminent people from various places are here. And Indian Association of Cardiac Imaging, and we are all here to see what is happening in the field of cardiac imaging. I am very proud that our radiology department as well as the cardiology department are doing wonderful job. Dr. Pudivan is doing all kind of job, and Dr. Vimal Raj was working, or our Pudivan was working with Dr. Vimal Raj, and I am very, very proud that you are all here. Please have a comfortable stay and have a nice day in Coimbatore. Wish you all the best. Thank you very much.
Thank you, sir. We'll continue with our next talk. The next talk is by Dr. Lilia, and it's on amyloidosis diagnosis with CMR, non-contrast, AL, ATTR differentiation.
So thank you again for this invitation. Okay, so I'm going to talk about the differentiation between AL and ATTR amyloidosis with non-contrast CMR, and more asymmetric for ATTR, but it could be eccentric or could be normal. So we need to take care, we need to be very careful about it. Then LGE. For LGE, we can have different patterns, and mostly it's a global subendocardial, that's the most common, and the transmural. But it is complex and it's challenging because of some details that we will see later. So the most common for ATTR is transmural involvement. Then the T1 mapping, the native T1 that Vanessa already told us about on her first talk, but this value can differentiate AL and ATTR. However, it's not that accurate because that could be some degree of overlap. It's a high value, but it could be in the same range. So it's very hard. So if we have the native T1 and the extracellular volume, AL used to have higher T2 and T1, and ATTR used to have a higher extracellular volume, but that's not always true, and we will see why I am saying that. In terms of native T1, it's said since 2014 that the native T1 is able to differentiate AL from ATTR, but that is not completely true. Yeah, okay. So even if we have a good performance, and in this paper about 2020, it seems that it would be a very good differentiation with a very good diagnostic accuracy in 42% of patients. That's not always true, okay? So in terms of the extracellular volume, we could see that the extracellular volume is usually higher in the ATTR comparing to the AL. And this is important because it depends of the amount of extracellular volume, the prognosis of the patient. The higher the extracellular volume, the worse prognosis of the patient. They have a lower survival. So it's important in terms of prognosis and in terms of response to treatment, mostly with the tafamidis that is available right now. So in terms of T2 mapping, usually AL has more edema. You can see here the more edema in the segments of the AL comparing with the ATTR, but that's not always like that. It could be less like in the previous one, or it could be more than in this one. So we need to be careful about it and see how there is a bit of overlapping. If we have the lower on the upper limits for each one, there could be some degree of overlapping, so we can make mistakes in make the diagnosis specifically for AL or ATTR. See, there is not such a big difference between AL and ATTR, and the error bars are frankly almost the same. In 2014, this group of Dungu said that this was the pattern of ATTR and this was the pattern of AL, and that the agreement with the QL, the quality score, was very good, and they said that this could differentiate between the two types of amyloidosis, but that during the next years, the evidence showed that that is not completely true. And most of them are not able to differentiate between the two types of the AL and the ATTR. Only two parameters are consistently different, which is the LV mass, which tends to be higher in the ATTR, and the native T1. So keep those in mind. Then the LGE. LGE is not as strong predictor as we used to think. Why I'm saying that? Because only 60% of the cases with amyloidosis has LGE, and the pattern is completely heterogeneous. See, you can have this one, which is the bad knolling of the myocardium, or like this, or you can have a global transmural enhancement or a diffuse transmural enhancement, or you can have these other heterogeneous patterns, such like this one, or you can have this focal patchy pattern, or the global subendocardial, or the suboptimal myocardial nulling. But those are highly problematic because of their incidence. See, for example, the bad nulling of the myocardium is only in 8% of the cases. And the PSIR sequence, which is routinely used in all the scanners right now, can fix that problem. So we can have a bad nulling of the myocardium, but it would be normal or normal nulling because of the PSIR sequence. So that's a problem. And the other pattern can mimic other diseases and are not as frequent as we could think. Then see the correlation with histology, which is something more worrisome. See this one, which has this global transmural pattern of LGE, and see what the histology says. So with the sulfurate Alcian blue, we can see that the collagen is pink and the amyloid fibers are green. And with that, see why almost everything is diffuse interstitial amyloid in this case, with minimal fibrosis. But see this case. See this case has very large LGE with different patterns. We can see that we have focal patterns in the right side of the interventricular septum that we have in the anterior wall and the inferior wall of less extensive of the interventricular septum and the right wall. And what happens with the histology? The histology shows us that the interventricular septum is a moderate interstitial amyloid, mainly in the right side, and the anterior and inferior segments has even less amyloid deposit, and the lateral has traces of amyloid. So that would give us the appearance and the patterns of LGE. So we cannot rely on just in the pattern that we obtain to differentiate, to make the diagnosis of amyloidosis and to make the differentiation between AL and ATTR. So there is a timing for this. It's just a hypothesis because there is no way to prove this. But first, the heart, even with amyloidosis, could look normal, with normal ECB and with no LGE. But then we'll increase the ECB, and still there would be no LGE. And then the ECB will increase, and the LGE will start in a subendocardial pattern. And then we will have a very high ECB with a large transmural LGE, and maybe at that point we will have a problem with the nulling of the myocardium. So it depends when we study the patient, when we are going to have these findings. So it's very complex. And for this one, we have a meta-analysis to see, we have a meta-analysis to see what is the diagnostic accuracy of those findings. Okay, so with that, well, I cannot show you, but it's around 3,000 patients. And with that, see that findings of CMR, mainly the LGE and ATTR LGE or the subendocardial LGE are not as good as SPECT, yes? So the current recommendations include SPECT to make the diagnosis with the Perugini criteria. So even if CMR is a useful test for diagnosing cardiac amyloidosis, it's good to diagnose, but is not reliable in further classifying the disease. So nuclear scintigraphy offers a strong diagnostic performance in both the detection of the cardiac amyloidosis and the differentiation of ATTR from AL amyloidosis. So this paper was from Slibinsky and Carolina Zareva from Ohio, but they are using the CMR registry. So many sites are collaborating. Actually, I am collaborating with this project, and see how these different types of amyloidosis, the ATTR and AL subtypes, are within the cases of the registry, and what the main findings are, as I mentioned, LGE alone is not as good as we used to think. But if we combine the LG plus the log locker pattern or the T1 scout, depending on the machine you are using it, plus the absence of light changes, light chains, sorry, the absence of light chains, we could have a very, very high test to diagnose ATTR and to discard AL cardiac amyloidosis. So that's something that maybe in the future we can use routinely, and that uses just the regular sequences. It's just the LGE and the log locker one. So comparing with the endomyocardial biopsy, the key now is the presence or absence of monoclonal light chains. And if we add that to the algorithm, we increase the sensitivity and the specificity of this of CMR to a sensitivity of 90%, a specificity of 98%, a positive predictive value of 99%, and a negative predictive value of 88%. But still, with those numbers are not perfect. So the current recommendation within the algorithms include the use of different strategies and not just CMR. So the diagnostic accuracy of CMR is now with a combination of different values or different parameters, which is the native T1 and the extracellular volume, which is even more accurate than longitudinal strain, because as you would know by echo, the longitudinal strain has a very common presentation, but that common presentation is very late in presentation. It's the last feature that we are going to find, this normal contraction of the apex that gives you the image of a Japanese flag. So that's not the current ideal moment to treat the patients, because the tafamidis, for example, should be started as earliest as possible. The best results, the best prognosis for the patient is when it is administered at the earliest stages. So what is the next step? The next step is artificial intelligence. And artificial intelligence with some neural networks really improve these things, because the artificial intelligence can see things that we cannot see. So for example, in this study, the authors used 70 patients with AL and 50 patients with ATTR, and with that, they obtained a better diagnostic accuracy, and they were able to discriminate between AL and ATTL and NTTR, comparing with a human expert. So that's something that maybe in the future would solve the problem, maybe for those cases that are usually visually difficult to diagnose. So the current algorithms, the ACC AHA 2023 expert consensus recommends CMR at the beginning of the algorithm, and then we need to go for the nuclear study to identify these perugenic criteria. The grade 2 and 3 are highly suggestive of ATTR amyloidosis, and to use the light chains to see if it's an AL case. So the corresponding algorithm from the recently released 2023 European guidelines do the same. CMR is at the beginning, and then we have a SPEC to see to identify the grade 2 or 3 perugenic criteria, plus the hematological test to see if it's an AL or an ATTR case, or is non-diagnosed, not diagnostic case. So in conclusion, the present data do not allow us to properly differentiate AL and ATTR with non-contrast CMR. AI will help in increased accuracy in that differentiation, but we need to think that in the meantime we should act with caution regarding the interpretation of CMR-based mapping findings in patients with AL or ATTR cardiac amyloidosis. So please act with caution. Follow the diagnostic algorithm, the ones proposed by either society, the IACI, or the European Society, and use SPECT imaging with the perugenic criteria and the hematological test. Thank you very much.
Thank you, Dr. Lilia, for your detailed inputs regarding the differentiation of AL from ATTR amyloidosis. I just have a question regarding the parametric mapping, and newer drugs have been there for the treatment of ATTR amyloidosis. Is there any role for the follow-up of these patients, with your experience?
Well, to follow up the patients with the parametrics, even with the LG sequences, it depends of reproducibility in your hospital. So if you are confident with your mapping values, yes, it seems that the native T1, it's useful to follow up these patients and the treatment of these patients. LG could be tricky because of this histological component, because it could change into fibrosis, and then the extracellular volume will change, and the distribution of LG will change as well. So only the native T1 is the one that is reliable for that.
Thank you. Any other questions from the audience?
Most of the cardiologists are not comfortable with endomyocardial biopsy in case we establish a diagnosis of amyloidosis on imaging. What are the extra cardiac biopsy sites recommended to establish the same?
So if, let me see if I understood your question well. It was about the myocardial biopsy, that not every center is comfortable with the endomyocardial biopsy, right? Yep.
Not every center is not comfortable with doing an endomyocardial biopsy. So is there any extra cardiac site that they can biopsy from?
No. No. The problem with endocardial biopsy is that you can obtain the tissue from the side that is not affected, or the preparation of the sample is not properly prepared, or your pathologist is not an expert in reading endomyocardial biopsy, so you can fail with the endomyocardial biopsy. So no, it's not routinely recommended, and almost no sites are doing this routinely. It's better to do biopsies in other places of the body, such as adipose tissue or salivary glands or something like that, for amyloidosis.
Thank you.
Any more questions? Thank you, Dr. Sierra, for a wonderful talk. I would request Dr. Elizabeth, ma'am, to felicitate Dr. Sierra.